Leukemia. Leukemia is a general term used to describe a group of malignant disorders affecting the blood and blood forming tissue of the bone marrow, lymph system, and spleen. Leukemia occur in all age group. It results in accumulation of dysfunctional cell because of a loss of regulation in the cell division. It follows a progressive occur that is eventually fatal if untreated. It is a metastatic cancer. It is originate and affect in bone marrow. Patients with leukemia, there is abnormal proliferation of mature WBC cell. There is blast cell within the bone marrow that will suppress bone marrow. It will leads to a pancytopenia. Pancytopenia means normal and healthy blood cells were decreased. Classification of leukemia. Acute lymphocyte leukemia, acute myelogenous leukemia, chronic myelogenous leukemia, and chronic lymphocyte leukemia. Etiology and pathophysiology of leukemia. Etiology and pathophysiology. Regardless of the specific type of leukemia, there is generally no single causative agent in the development of leukemia. Mostly leukemias result from a combination of factors, include genetic and environmental influences. Chromosomal changes first recognized in chronic myelogenous leukemia have led to discovery of how normal genes once transformed can result in abnormal genes capable of causing many types of cancer, including leukemias. Chemical agents, chemotherapeutic agents, uh, example alkylating agents, virus, radiation, and immunogenic defensives, uh, and have all have been associated with the development of leukemia in susceptible host. There is an increased incidence of leukemia in radiologists. Persons who have lived near nuclear bomb test site or nuclear reactor accident survivor of the bombing of Nagasaki and Hiroshima and persons previously treated with radiation therapy or chemotherapy. Although RNA retrovirus cause a number of leukemia in animals, a viral causes for a human leukemia has been established only the some patients with adult T cell leukemia. This form of leukemia is endemic in southwestern Japan and a part of Caribbean and Central African and is caused by the human T cell leukemia virus type 1. Classification of leukemia can be done based on the acute virus chronic and on the type of WBC involved. The terms acute and chronic refer to the cell maturity and nature of the disease onset. Acute leukemia is characterized by the colonal perforation of immature hematopoietic cells. The leukemia develops following malignant transformation of a single type of immature hematopoietic cells followed by cellular replication and expansion of that malignant clone. Chronic leukemia involves more mature form of WBC and the disease onset is more gradual. Leukemia can also be classified by identify the type of leukocytes involved, whether it is a myelogenous origin or of lymphocytic origin. By combining the acute and chronic categories with the cell type involved, specific types of leukemia can be identified. Four major types of leukemias are acute lymphocytic leukemia, AML, chronic myelogenous leukemia, and chronic lymphocytic leukemia. Other defining already we will discuss the classification of leukemia in detail. Acute lymphocytic leukemia ALL. Age of onset is younger than 15 years of age. Lymphoblast cell overproduction within the bone marrow. Acute myelogenous leukemia. Its onset is between the age of 15 to 39 years. Mostly Myeloblast cell overproduction within the bone marrow. Chronic myelogenous leukemia, that means age of onset, the 4 decades, age of 40 to 50 years. Granulates, differential leukocytes are overproduction within the bone marrow. Chronic lymphocytes leukemia, that means age of onset is above 50 years of age. Overproduction of lymphoblast with the bone marrow. Clinic, Clinical manifestation. The clinical manifestation of leukemia is varied. Essentially, they are related to problem caused by bone marrow failure and the formation of leukemic infiltration. Bone marrow failure results from bone marrow overcrowding by abnormal cells and inadequate production of normal marrow elements. The patient is predisposed of to anemia, thrombocytopenia, and a decreased number of function of WBC. As leukemia progresses, fewer normal blood cells are produced. Then abnormal WBC can continue to accumulate because they do not go through the normal cell life cycle of death. The leukemic cells infiltrate the patient's organ, leading to problems such as splenomegaly, hepatomegaly, lymphadenopathy, bone pain, meningeal irritation, and oral lesion. Solid mass resulting from collection of leukemic cells, chloromas, can also occur. Common clinical features are fatigue, weakness, headache, mouth ulcers, anemia, bleeding, fever, infection, sternal tenderness, gingivitis, hyperplasia. These are the clinical manifestations seen in acute myelogenous leukemia. If the patient has acute lymphocytic leukemia, the common clinical manifestations are fever, pallor, bleeding, anorexia, fatigue, weakness, bone and joint and abdominal pain, lymphadenopathy, infection, weight loss, hepatosplenomegaly, headache, mouth sores, neurological manifestations including CNS involvement, increased ICP, secondary to meningeal infiltration. Chronic myelogenous leukemia, no symptoms early in disease, fatigue and weakness, fever, sternal tenderness, weight loss, joint pain, bone pain, massive splenomegaly, increasing in sweat at the later stage. In chronic lymphocytic leukemia, the symptoms are initial stage, no any other symptoms present. Detection of the disease often during the examination for unrelated condition. Chronic fatigue, anorexia, splenomegaly, lymphadenopathy, hepatomegaly may progress to fever, night sweats, weight loss, fatigue, and frequent infections are the one of the clinical manifestation. Diagnostic studies. Diagnostic studies, peripheral blood evaluation and bone marrow examination are the primary method of diagnosis and classifying the subtype of leukemia. Morphological, histochemical, immunological, and cytogenic methods are all used to identify cell subtype and the stages of development of leukemic cell population. This is important because different subtypes have different natural histories, prognosis, and chemotherapeutic regimen. Other studies such as lumbar puncture, CT scan can determine the presence of leukemic cell outside of the blood and bone marrow. The malignant cell is most in patients with ALM, AML, and ALL have chromosomal abnormality. In some cases, specific cytogenic abnormalities are associated with a distinct subset of the disease. In addition to establishing the type of AML or ALL, specific cytogenic abnormalities have diagnostic, prognostic, and therapeutic importance. In CML, the findings of Philadelphia chromosome has diagnostic value. The most appropriate diagnostic measure of leukemia is bone marrow aspiration and biopsy. Site of bone marrow aspiration either iliac crest or sternum or posterior iliac crest or anterior iliac crest, we always collect the sample. Children and infants, we usually collect the sample from tibia and fibula bone. Results shows large number of blast cells and large number of normal cells. Once again, I will repeat. Large number of blast cells and low number of normal blood cells are seen in this test. Complications and clinical symptoms of leukemia. Complications are bone marrow suppression, thrombocytopenia, anemia, extremely low platelet count in blood, splenomegaly, hepatomegaly. These are the main complications of leukemia. Management or intervention. We will discuss the collaborative care of leukemia. One of diagnosis of leukemia has been made. Collaborative care is focused on the initial goal of attaining remission. Age and chromosome analysis often help from the basis of important treatment decision because cytotoxic chemotherapy is the mainstay of the treatment. The nurse must understand the principle of cancer chemotherapy, including cellular kinetics, the use of multiple drugs rather than single agent, and cell cycle. In some cases, such as non symptomatic patients with a CLL, watchful waiting with a active supportive care may be appropriate. Although the patients may not be cured, attain remission of or disease control is realistic option for the majority of patients. In some cases, cure is realistic goal. In complete remission, there is no evidence of overt disease and on physical examination and the bone marrow and peripheral blood appear normal. A lesser state of control is known as partial remission. Minimal residual disease is defined as tumor cell that cannot be detected by morphological examination but can be identified by molecular testing. Partial remission is characterized by a lack of symptoms and a normal peripheral blood smear, but there is still evidence of disease in the bone marrow. Molecular remission is defined as blast cell in the bone marrow. The patient's prognosis is directly related to the ability to maintain a remission. The patient prognosis become more unfavorable with each relapse. Each time there is a relapse, the succeeding remission may be more difficult to achieve and shorter in duration. Sometimes patients have such a higher WBC count that initial emergent treatment may employ the use of leukapheresis and hydroxyurea. The purpose of these treatments is to reduce the WBC count and risk of leukemia induced thrombosis. The chemotherapeutic agents or treatments of acute leukemia is often divided into stages. In the first stage, induction therapy. It is the attempt to induce or bring about a remission. Induction is aggressive treatment that seek to destroy leukemic cells in the tissue, peripheral blood, and bone marrow in order to eventually restore the normal hematopoiesis on bone marrow recovery. During induction therapy, a patient may become critically ill because the bone marrow is severely depressed by the chemotherapeutic agent. Throughout the induction phase, nurse interventions focus on neutropenia, thrombocytopenia, and anemia, as well as providing psychosocial for induction of AML induced catrabin and anti-tumor antibiotics such as doxorubicin, idrarubicin, mitoxantrone. After one course of induction therapy, approximately 70% of newly diagnosed patients achieve complete remission. There is one type of AML called promyelocytic leukemia, in which Tetrayon is used along with the chemotherapy to induce a remission. It is generally assumed that leukemic cells persist undetected after induction therapy. This could lead to relapse within a few months if not further therapy is administered. Terms used to describe post-induction of post-remission chemotherapy include intensification, consolidations, and maintenance. Intensification therapy or high dose therapy may be given immediately after induction therapy for several months. This therapy may use the same drug as those used in induction but a higher dosage. Other drugs that target the cell in a different way than those administered during induction may also be added. Consultation therapy. Consultation therapy is started after a remission is achieved. It may consist of one or two additional courses of the same drug given during induction or involve high dose therapy. The purpose of consultation therapy is to eliminate remaining leukemic cells that may not be clinically or pathologically evident. Maintenance therapy. It is treatment is with a lower dose of the same drug used in induction or other drug given every 3 to 4 weeks for a prolonged period of time. Like consolidation or intensification, the goal is to keep the body free of leukemic cells. Each leukemia requires different maintenance therapy. In AML, maintenance therapy is rarely effective and therefore the rarely administered. In addition to chemotherapy, corticosteroids and radiation therapy can also have a role in the complex therapeutic plan for the patient with leukemia. Total body radiation may be used to prepare a patient for bone marrow transplantation, or it may be restricted to certain areas such as the liver, spleen, and other organs affected by infiltrates. ALL, prophylactic interthecal methotrexate or intervention for the patients with leukemia. The patients with leukemia, the client is at risk of bleeding when the platelet fall below 50% and the spontaneous bleedings occur from the lower than 20% of patients is at risk for bleeding fall below. The client with platelet count lower than 50%, we need to platelet transfusion. Bleeding precautions patients is leukemia. Intensive procedures should be avoided to reduce bleeding. IM injection should be avoided. If any injection taken, we will provide firm pressure applied in the prolonged time. Avoid injuries, abrasions, especially superficial injuries. Instruct the patient to use soft tooth brush. Avoid hard brush. If it is used to hard brush to change to it will get a chance to gum bleed. Shave if the patient instruct that to use electric razor or electric trimmer should be used. Instruct the client to avoid blowing the nose. Avoid rectal procedures, rectal temperature or rectal catheter insertion. It may leads to bleeding. If the client is menstruating, assess the menstruation count, the number of perineal pads if the client is used. We will assess the patient. Instead, the client should avoid NSIDs. Neuropathic precautions of leukocytopenia precautions. It may chance to reverse infection and prevent positive pressure isolation. Please the patient. If not available, provide single room isolation. Wear the mask, close the door. Visitors entry is restricted. People who have entered should be wear gloves and gown before the contact to that patient. Wash the hand, it is must be maintained. Use strict aseptic techniques for all procedures. Staff and visitors non-infection or exposure to communicable disease should avoid contact with the client. Keep supply for the client from separate from supplies for other clients. Keep frequently used equipments in the room for the client use only. Limit the number of staffs entering in that room. Reduce exposure to the environmental organism by eliminating the fresh or raw fruits and vegetables from the diet. Avoid place keeping fresh plants, flowers from the patient's room. Instruct the client to take bath with the antimicrobial soaps. Oral hygiene it should be maintained. Avoid urinary catheterization. Avoid urinary catheterization. Instruct the client to avoid crowds. Live vaccination should be avoided because it may chance to get infection. Recurrent infection related death. Infection is the major cause of death in immunosuppressed patient. Diet. A leukemia patient should follow a high protein, high calorie, high fiber, fiber rich and vitamin and iron rich food. Hydration status should be maintained. Rest is adequate needed. Chemotherapy, bone marrow transplantation are the other type of leukemic treatment.